Ray Engel, Rachel Gartner, Beth Mulvaney, and Elizabeth Zimmerman Clayton, I helped to lead two of the programs that are co-sponsoring today's event. The COAL, which stands for Coalition for Opioid and Addiction Leadership, and the Hartford Partnership Program for Aging Education. Professor Mulvaney and I also are proud to partner with Martha Landolina, Heather Santa, and Joshua Hoffman from the PERU program in pharmacy. PERU stands for the Program Evaluation and Research Unit. And they're also co-sponsors of this event today, serving older adults with substance use disorders. Having this event co-sponsored by the Hartford Fellowship, the Hartford, and PERU, and focused on the issue of aging and substance use is particularly exciting for me. When I arrived in Pittsburgh 20 years ago, I became interested in older adults with opioid use disorders. At the time, prior to our more recent opioid epidemic, older adults in methadone maintenance programs were primarily those who had been using heroin and other opioids since they were younger and were now aging. As I began to explore the service needs of this aging population, it became evident that there was not a tremendous amount of awareness of this population or a developed understanding of the supports and treatment needs that these individuals required as they aged. My initial attempts to obtain funding and publish about older adults with substance use disorders who did not have an issue with alcohol were extremely challenging. Over the years, I have seen more acceptance to addressing the specific treatment needs of older adults with substance use disorders. Unfortunately, the need is as great as ever. In the past 2 years, the intersection of the COVID-19 pandemic with the opioid epidemic has had a devastating effect across the country and also here in our region. Since the onset of the COVID pandemic, over a quarter of the overdose deaths in Allegheny County have been individuals over the age of 55. Thus, the opportunity to learn from the scholars and practitioners on the panel today is vital and critically important as we grow our capacity to address this crisis. I'm going to introduce the panel in the order that they will be speaking. Each panelist will speak for about 20 minutes, and then we will open the Zoom floor for questions and discussion. If you have questions during the presentation, please put them in the chat, which Elizabeth and I will be monitoring. First up, we're going to have Dr. Carmen Morano, who will be giving a talk on an overview of older adults and substance abuse disorders. Dr. Morano is professor and director of the doctoral program at the State University of New York, University at Albany School of Social Welfare. In addition to being a John A. Hartford faculty scholar, Carmen serves on the Veterans Administration Geriatrics and Gerontology Advisory Committee. His research focuses primarily in the areas of gerontology, healthcare, and interprofessional collaboration and education. Dr. Alexis Kubris will be going after Dr. Morano and talking on age-appropriate interventions. We're particularly excited to have Dr. Kubris here today because she gives us a social work perspective on these types of interventions. Dr. Kubris is an associate professor at Silberman School of Social Work at Hunter College of the City University of New York. She is a licensed clinical social worker with 20 years of experience in a variety of clinical, public health, and social service settings, and specializing in substance abuse treatment. She has developed a program of research that centers on enhancing social works and other disciplines, understanding of the unique aspects of substance use and abuse among older adults, including assessment, diagnosis, health guidelines, patterns of daily use, and building and/or honing effective brief interventions and other treatment for their optimal care. Our final discussion will be with Dr. Roy and Ms. Francis, a social worker. They'll be doing their presentation together on a case study in interprofessional care. Dr. Roy is an assistant professor of medicine at the University of Pittsburgh School of Medicine and clinical director of the Addiction Medicine Consult Service at the University of Pittsburgh Medical Center. Prior to moving to Pittsburgh, she completed her Addiction Medicine Fellowship training at Boston University School of Medicine, and completed research training with the Integrated Care for Addiction, HIV, and HCV Research and Education Fellowship at Boston University School of Public Health. Her research interests are centered on low barrier access to treatment for opioid use disorders and trainee education in addiction. Particularly excited to welcome Sharia Francis, an alum of our School of Social Work here at the University of Pittsburgh, and she also serves as a field instructor for the Cole Fellowship program. She currently works as a senior social worker at UPMC Presbyterian Shadyside Hospital and works with the Addiction Medicine Consult Service. Over the past 10 years, Mrs. Francis has developed an extensive background working with individuals with substance use disorders in a variety of clinical settings. Her passions continue to include working with individuals who have substance use disorders and comorbid mental health trauma histories, and consistently pursues clinical excellence by furthering her education and training in those areas. This time, I'm going to hand it off to my friend and colleague, Dr. Marano.
Thank you very much, Dr. Rosen. It's a pleasure to be here. I guess if I were to say for today's brief amount of time, if there's a theme or a takeaway, I think it's the saying, what goes around comes around. When I think about substance abuse and older adults, I can't think of a more appropriate theme. So with no further ado, what I'd like to do is share my screen, and we'll proceed, and hopefully I can stay on time with all of this. Bear with me as I set her up. All right, I believe we should be able to see my screen. So a special thanks to everyone that Danny's already mentioned, but I also want to give a special thanks to Danny. What goes around comes around. We were just chatting. I think I first met Danny over 15 years ago, where he was really one of the leaders in the field of exploring the phenomenon of substance abuse within the aging population. And the work that he's done in this area has just been cutting edge. So I want to give a special thanks to him. Many of the slides that I'll be showing come out of some of the work that Dr. Rosen and his colleagues have done. If I can succeed, hopefully what we'll try to do is cover from what is the scope of the problem of substance abuse and substance use disorders with older adults, identifying some of the risk and protective factors, and trying to focus a bit of my discussion on what are the implications for these changing dynamics going forward, and then look at some strategies that we might be able to apply. I think one of the starting points for this discussion is recognizing that how we define older adults really varies. And on the screen there's a variety of different ways that we look at it, and if you will, institutions look at aging here in the United States. But I think when we try to homogenize this group as individuals over 60 or 65, the fact of the matter is that they aren't a homogeneous group. They're very diverse. And none of that homogenization really does take into consideration the life course of this cohort that we're talking about. So when I think of the aging population in older adults over whatever age you start to think of them as approaching it, I look at that life course and their access and the cumulative advantages and disadvantages, and how do they account for substance use disorders and our ability to not only recognize it, but respond to it. When we're talking older adults, here in the United States, over 75 million people. And what we know demographically, things are changing. At one point, I had a slide that talked about is demography destiny? And we recognize that the shifting demographics of the United States demands a more culturally humble approach to how we not only develop and design the programs, but also how we improve access to the kinds of services that individuals are going to be needing. And what I'd like to put as an overlay, when you think of the social determinants of health, and we think of the economic conditions and the access to education and neighborhoods and the environment and the social community, and what is mainly the focus today within the determinant of healthcare, how individuals' unequal access to each of these determinants have implications for us in the field of social work, because when you think of the social service sector, we serve clients in these various areas, which are touch points where we can begin to recognize perhaps and provide more preventative services going forward. There's no question about it, and I do take exception to this being labeled a baby boomer. I guess I could say at the age of 71, what you see here in the screen in terms of what I represent as a baby boomer, you now know what one baby boomer represents. And that's all you can determine by that. But the one thing I hold in common with my cohort is that wherever we've traversed from the beginning, from birth through to now being classified an older adult, and I will take exception to that label that you foisted upon me, we've affected every system that we've ever come in contact with. And when we think of substance abuse and drug use, we certainly see that the rates, the percentages through the 20s, through the 40s, and now into the 60s, we've led, or we lead, what any other cohort has demonstrated or has been found to have to this point. Lots of contributing factors that we look at. One, the use of prescribed medications. And again, when we think about the prescription use with older adults, not only we're talking about the fact that they're at risk for misusing them and not perhaps taking them as prescribed, but think about, again, the life course of our cohort, of my cohort, the amount of medications that we've been prescribed throughout our history. When we look at substance abuse specifically, and we look at the ages, if you will, the percentages of individuals who are admitted to treatment, it doesn't look that overwhelming at only 7%. But when you look at this by the type of substance, you certainly see that alcohol stands out amongst what we know to date. Unlike where we see opiates, cocaine, and other substances, the percentages dropping, alcohol continually shows an increase as the individuals age. We know that right now, from SAMHSA's data, that over 73 million people have either an acute mental illness or a substance abuse disorder been diagnosed within the last year, and almost 38 million individuals have had a substance abuse disorder identified in the past year. And if you look at them combined, what the slide shows, that the overlapping comorbid substance abuse and mental health, you're talking about a population of over 17 million individuals. And as the previous slide showed, alcohol is one of the most frequently abused substances that older adults experience. And this provides just the statistics, which really lead you to recognizing the fact that when we're working with our populations, regardless of that service sector we might be in, 13%, and that is frequently thought of as an underrepresented amount, but 1 out of 10, 2 out of 10 possibly have experienced a substance abuse disorder in their lifetime. With the older adult population, the intersection is even more critical, because we also look at how a life course of substance abuse disorders, and particularly with alcohol and prescribed medications, we see the comorbid problems that intersect with ranging from diabetes to memory problems and mood disorders. So when we're in the position of working with this older population, it's not just the substance abuse disorder, but we need to recognize what are the other systems that might be impacted by the substance abuse in and of itself. We mentioned prescription use amongst the aging population, and there's again evidence that shows pain relievers. And Danny in the introduction was talking about opiate use. If anyone's watched Goliath or Dropout, the presentation of how we got to this particular problem of prescription overuse of prescription and prescribed medications. It's mind-boggling that we've been allowed to, I say have done nothing. I guess I'm speechless, and that's hard for me to get to. But the fact of the matter is that pain relievers, as they've been prescribed, are one of the biggest culprits that we need to be mindful of with this old aging population. The other fact is, if we add this other overlay, which is that as we look as the individual ages, the amount of drugs. So when we look at, from 1999 to 2016, what you see at that top bar where 5 or more prescribed medications are being given to older adults, we see that as you get closer to that 2015-16, not only has that percentage increased, but it now seems to have plateaued. And where we go from there, I think that's yet to be determined. Opiate use, we've not only recognized that there's the increased hospitalizations, but the fact of the matter that the unintended consequences of the individual who is abusing opioids throughout the family system, the ripple effects, again, when I think about the implications for us within the field of social work, need to recognize that, again, it's not solely the individual. Yes, they're the primary patient that we identified patient, but it's the family system and the ripple, the consequences that emerge from that individual's substance abuse disorder need to be considered in the work that we're doing. And now we're at the point where when I go out to dinner with some of my contemporaries, the question that will circulate and at tables around us, certainly not at my table, is, well, have you gotten your medical marijuana card? And there is a reality that we have taken what has been traditionally used as a sledgehammer by the criminal justice system to further an agenda that is a lecture for another day, is now something that has been brought into our social capital enterprises throughout the United States. So when we think of older adults and cannabis, these statistics that date back to 2019 really will need to be looked at as we go forward. But there is this increased risk. And again, we need to be mindful of those, the potential consequences that some might experience, like psychotic episodes, stroke, and increased risk of heart attack. But I don't think those threats to the older adult population would have any more impact than the threats my cohort heard when I was in my teens in the 1960s. So take that for what it's worth. When we look at the barriers, why aren't we identifying it enough, and why 13% probably isn't a fair representation? Clinicians don't always have not traditionally screened, although that's now built into every intake or every visit I have with my primary care physician. There's thoughts about that are just negative, and people don't like to talk about the fact that perhaps someone they have always looked up to was experiencing problems with a particular substance. There's a lack of knowledge on the provider system, and thanks to the work that's being done here at UPIT, hopefully we're addressing that. But many primary care physicians, within that 7-minute envelope that they have to speak with a patient, don't have the time to be able to really explore the extent of what might be occurring in the life of their older patients. There are a number of risk factors that I'd like to cover, and I want to just double check my clock here to make sure I'm not going to come up against the end here too quickly. But certainly the risk factors from losing a spouse or a partner to retirement. I added a point here on adaptation to technology, the use of technology in both social service delivery, but particularly in healthcare delivery. How are we preparing a cohort that we are immigrants into technology? And although I might think I have some competence in using it, I know daily that I don't. So there we go. I like to look at this from a strengths-based perspective, and again, in our field of social work. So looking at the protective factors and recognizing that we get more bang for our buck, if you think of it that way, by trying to build upon and expand these protective factors in terms of social networks and the capacity to live independently and safely, and looking at how we can use the time we spend with this population to help understand how do they perceive themselves, because self-image will have a major factor in determining our success in whatever the auspices of our agency is in delivering the services. I think for us in the field of social work, particularly, there's a lot of implications. First and foremost, we need to be able to think and be prepared to practice in an intercollaborative setting. But I also think we in social work represent one of the only professions that are schooled in both systems thinking as well as the group process. So as we think of working intercollaboratively, not only do we need to think about our role in representing the clients we work with, but think about our role as social workers and seeing what we might be able to add to our teams, our healthcare teams, to be a more effective and efficient team in working. I certainly encourage you to go beyond just the on-the-job training and seek continuing education to develop your skills in this area. And I know, again, UPIT and Dr. Rosen specifically has been a leader in that area. We need to develop and improve our competence in working with older clients and recognizing that they're a very heterogeneous group. My life from 50 to 60 was very different than my life now from 60 to 70. And having worked in the field for over 25 years in direct practice, I know my life from my 70s to 80s and 80s to 90s. And as they say, God willing, 90s and to become a centenarian is going to be very different. I represent an N of 1. Each client you come in contact with needs to be looked at within the context of their life course, within the context of all these social determinants that I've been speaking to, as well as their current context of our society, which coming up from Manhattan yesterday gives me great pause. So we need to work with not only individual clients, but their broader informal as well as the formal systems we represent in our profession. We need to continually monitor what is the impact of the cumulative advantages that individuals like I have been blessed with and the disadvantages that others and the clients we come in contact with have experienced. Understanding, as I said, the heterogeneity, that we're not a monolithic group, both in terms of culture and orientation, gendered expression, relationships, how we define older adult can only be defined within the context of the client that we're working with, and not with, I'm sorry, with homogenized or stratified data that can give us some broad understanding. But as we say, when the rubber meets the road, when we begin the work we do, we need to recognize all of the intersection of this. And again, here we're social work having a systemic and systems grounded approach to what our education is, should help us recognize that there is no one magic touch point, that we need to look at the multiple touch points and how we can collaboratively intersect with not only the treatment of, but hopefully more importantly, the prevention of substance abuse. Key points, I think I've said it already. Again, I don't know, I might be coming up against the clock. If someone can give me a time check, because I wasn't sure when we got started. But
two-minute warning, Dr. Marano, 2-minute warning.
Thank you. So again, I think the key points need to be, one, for sure, the diversity that I've spoken on a lot. Recognizing that alcohol is the most commonly used substance by older adults. Those risk factors of retirement and loss, our coping mechanisms will lead us to increase use, and alcohol has by far been the drug of choice of our cohort, this cohort, moving forward. Diagnostic criteria alone, I stayed away from the DSM-5 for this particular 20 minutes. Sorry, there is my timer going off. We need to be mindful of this, the intersection of all the challenges that the older adults face, and certainly that we need to improve and increase and replicate the kind of training that you, Pitt, and Dr. Rosen are doing out there in Pittsburgh. And at that, I'll sign off from dreary downtown Albany.
Dr. Marano, thank you very much. Dr. Kerbis, are you able to share screen?
Yes. Hold on. Let's see here. Hi, everyone. It's so exciting to be here today to talk to you about this topic. And it's really wonderful. And thank you, Dr. Rosen, for bringing us all together, because I think, this is a really, really wonderful and unique opportunity. So I just want to start by having a land acknowledgement for those of you in Pittsburgh that we are on borrowed, stolen land from the Shawnee and the Osage in Pennsylvania, and then in New York City, where I'm located, the Canarsie, Lenape, Matinecock, and Wappinger peoples. Always important to acknowledge what came before. So I just want to impart what are my philosophical approach or my frame that is very much embedded in social work. So my approach is very client-centered, and I believe that clients have informed consent or need to have informed consent in order to make the right decisions. They have a right to self-determination, however, and sometimes that can be really difficult when working in substance use across the board, but also in specifically with older adults. And I really try to take a harm reduction frame, which tends to welcome older adults into the fold of, I won't say formal treatment, but evaluating their own health and well-being and how any substance use fits in there. There are going to be some cases where abstinence is the only safe option, and I reserve the right to say that to my clients. But many providers have fears about assessing for substance use in general. A lot of people think they have to know everything there is to know about a substance. And I try to really, educate my students and my colleagues to say, it's okay if you don't know, ask. And oftentimes when we think we know everything, we end up not asking or making assumptions. Also, I've heard a lot of providers feel like they're disrespecting an older adult if they ask about substance use. And given the prevalence rates that Dr. Marano just went over, I think it's safe to assume that There's a much more open culture towards substance use than in previous generations. And so it's not necessarily a sign of disrespect. So how to speak with older adults about substances, really, I can't say this enough, make no assumptions. Really, you can normalize the fact that people of all ages use substances, using a non-aggressive, supportive tone. That applies to every single person who uses substances. The days of confronting denial are long gone, and we know they actually are harmful and entrench people in substance use. Asking very direct questions. How many standard drinks do you have each day? And then really respecting the client's self-determination, not infantilizing them, not talking down to them. The goal, and Dr. Morano already alluded to this, is not to diagnose a substance use disorder, but to identify potential harm or problems. And the reason being that the DSM-5 does not take into account the unique circumstances of an adult in later life. And as a result, the people who get identified with an alcohol use disorder or another substance use disorder tend to be the most severe cases, whereas in younger populations, we really get a nice spectrum. So what that means is that older adults are often diagnostic orphans. But that doesn't mean they don't still require intervention for optimal health. But it's important to note that in the formal substance use disorder treatment, they often require a very specific diagnosis in order to provide treatment. So this could be a barrier to care. I am not going to talk about the specifics of screening and assessment, but I have sent to Elizabeth a number of handouts that walks you through standardized measures, scales, questionnaires that you can use, different questions you can ask, and then also the specifics of diagnosis, how each criteria may or may not fit with an older adult. But what I want to focus on in my presentation is really existing interventions. And so when we think about what kind of intervention is indicated, we need to first think about how much harm is there to the client. Is the client safe, and do they have access to care? We also want to assess, okay, so what's the intensity required? Do they need hospitalization for detox, or do we need something a little more brief? Is it okay that we start with just a brief intervention? And we also want to be cognizant of fitting our intervention with client goals. It may be that an older adult is interested in moderation. And so if you refer them or recommend going to a 12-step program, they're not likely to go because that doesn't fit with their goals. So the level of intervention by professional providers really ranges and starts from psychoeducation and brief advice to outpatient counseling and sometimes some medication. And then we have inpatient care, which Dr. Roy is really going to talk about, and Ms. Francis. So I'm going to be focusing on the first two. I really want to drive this home that psychoeducation empowers older adults to make well-informed decisions. Recently, in the March of this year, the AARP newsletter did a whole article about older adults and substance use. And I suddenly started to get a bunch of calls from all my mom's friends saying, oh my God, I didn't know. I didn't know that substances could be so harmful to me at this age, even though I've been having a martini every day for the last, 20 years. And so even just getting the information out there so that people understand that when you start at around age 50, your body and brain, they're changing, unfortunately. And we're not told that, we're not prepared for that. And so we just continue our habits through our life, and that can have some serious consequences. When we get to more formal brief advice, it's usually provided by a physician. And oftentimes it's, a 15-minute intervention, which is laughable, especially given Dr. Morano's, suggestion that it's more like 7 minutes. And so you can see the impossibility of these really short-term interventions. They are now sort of delegating these brief interventions to behavioral health coaches within primary care, which provides, it can include psychoeducation, some nod to enhancing motivation for change, and then connecting with more intensive treatment if necessary or possible. So I've already mentioned 12-step peer recovery. It's in the community. If a person is interested in abstinence, then of course that's going to be a good support. It is an evidence-based practice. It is one of the most successful interventions. However, if you don't have a client who wants abstinence, then you might have the opportunity to use motivational interviewing and cognitive behavioral therapy, which can be used either in the more intensive treatment settings, or it can be used in a brief treatment setting. So those of you who may be familiar with motivational interviewing, many people assume that motivational interviewing can be applied indiscriminately, and I'm here to hopefully educate you otherwise. First, it's a conversational style that targets motivation and self-efficacy of a client. So it really helps the client identify why should they change and do they feel capable of change. And we know that motivational interviewing does seem to have minimal efficacy on other health behaviors like medication adherence. It's minimally effective for things like diet and exercise among older adults. But we have, and I should say, that for motivational interviewing, its efficacy is entirely dependent on the target behavior. Because, for example, in one meta-analysis of motivational interviewing, it'll work for some substances, but it does not work for smoking cessation. So when we take that into account, and the fact that adults over the age of 63 have not been included in randomized controlled trials testing motivational interviewing for drinking or other drug use, we've got a really big gap in the literature. The impact of age on MI is completely understudied, and of those very few studies that have addressed it, it's mostly null findings. So I'm just going to briefly talk about some research that I've done looking at how does 4 sessions of motivational interviewing compare with 4 sessions of Rogerian non-directive listening among older adults with AUD, and then how does that compare with their younger counterparts. So I combined these data sets from 2 randomized controlled trials, which repeated the same protocol, and it ended up with 60 older adults. And here I define that as older than 51 and up to 73, and 108 younger adults. And there was an even split of age between the 2 conditions of MI and non-directive listening. So we see here that there were no significant baseline differences between older adults and younger adults. The yellow line represents motivational interviewing. The purple line or lavender line represents non-directive listening. And what we see is that by the end of treatment, older adults drank 45% more than younger adults, just across the board. That was the main effect of age. And then we see that among older adults only, motivational interviewing has a slight improvement or edge over non-directive listening. It's only about a 5% difference statistically, and so it's at least minimally effective. I think probably more accurate to say that non-directive listening alone is not effective at all. We also see that when we compare the 2 age groups, MI and non-directive listening, I'm sorry, those are the interventions. When we compare the 2 age groups across just MI, which are the yellow lines, there were no significant differences across the age groups. So MI conceivably works equally well among both groups. What we do see, however, is that non-directive listening works far better for younger adults. There was a significant reduction, and younger adults reduced their drinking by 30% more than older adults. So that all to say, and I do mention this later in my presentation, that, there is some evidence that motivation and self-efficacy perhaps are not as protective for older adults as they are for younger adults, but also that older adults might need something more proactive and engaging. And this brings us to cognitive behavioral therapy. It really focuses on the how of change, develops coping skills for triggers, and requires practice in the real world. And this is actually the largest evidence-based practice, or the most supported, but that is only 3 studies that have specifically tested this. And so we do have some evidence that cognitive behavioral therapy does work, but most older adults have been excluded from most studies of CBT. So generally speaking, the jury is still out. So I also wanted to look at whether among individuals with AUD interested in moderated drinking, what is the moderating impact of age on the efficacy of MI and CBT? And I did a secondary data analysis of this adaptive intervention where people were brought in, given MI or brief advice, then they were followed for 4 weeks. And if they didn't respond, if there was no clinical change, they were re-randomized to either more motivational interviewing and or CBT. And I broke this one up into 3 age groups. So because of the sample size, and we had ages 22 to 47, ages 48 to 56, and ages 57 to 73 years old. We did not find a moderating effect of age on MI or CBT, and that suggests that older adults respond equally well to brief interventions to AUD as their younger counterparts. However, there was a main effect of age. So if we see here, the white lines are the middle-aged group, and the youngest group is the yellow line, and the oldest group is the green line. And we see that the older adults and the younger adults tend to stay at least from week 4 to week 13 in this study in the same kind of range, but that these interventions are actually working much more effectively, it looks like, or at least just being in the study causes the middle-aged group to reduce their drinking. That could be a number of different reasons, and I will happily discuss that if people have questions about it. But I think that one could be that there's just a lot more role responsibility in middle age than the other 2 age groups. So again, neither of these groups made a huge amount of change during treatment, I should say. And overall, any CBT improved outcomes, and the best combination for anyone was 2 sessions of MI at week 4 combined with CBT later. But these treatments are insufficient, and people are still drinking at hazardous levels by the end of treatment. And so we just don't know about the mechanisms of change across the lifespan. And here again, enhancing motivation and self-efficacy may not be as protective for older adults compared to their younger counterparts. I do think it's important to say that older adults can be successful in mainstream treatments, but they do best in the age-specific programs. The data we have that shows this, however, are those people who self-select into treatment programs, and they tend to be the most severe cases. So there's a huge swath of people that never make it to treatment. Age-specific adjustments include age-specific groups where they're homogeneous by age, a slower pace of learning, accommodations for all levels of abilities like literal physical access to the treatment program. And research supports these adjustments. However, there isn't a whole lot that's been done on this. It's only a few studies, so more needs to be taken into consideration. Next steps in psychotherapy are the application of problem-solving therapy and ACT, acceptance and commitment therapy. These are definitely happening out there in the research world, but they have yet to really make it to mainstream treatments. And then the last word on existing treatments, I just want to say that naltrexone is a medication that has been found safe and effective for older adults. It's the only medication for alcohol use disorder and opioids that has been shown to be quite safe. It's thought to work by reducing cravings, but we don't actually have proof of that yet. It's very safe. People with HIV can take it. It doesn't interfere with their cocktails, their ART. And again, this is the only medication tested on older adults. Like a Chantix or naltrexone can cause severe increases in depression. So that's the one thing that really needs to be monitored. Dr. Morano talked about these already, and I know I'm running out of time, so I won't go through this in any detail except to say that there is still this attitude of one last pleasure. There is also a lot of confusion between substance abuse versus aging. People think they miss the signs of substance use for the signs of actual aging. People who are older want privacy. They tend to underreport. There's lots of fear and stigma. They don't have knowledge and they tend to avoid treatment, which is why there are new frontiers in treatment, specifically apps and text messaging that I'll just show you. Because I know Dr. Rosen had wanted me to talk about this. I did, along with my colleague Fred Munch, we did a text messaging intervention to reduce hazardous use, and we got a naturally occurring older population, a big subsection of older adults who sought treatment. Thank you for the 2-minute warning. And what we see here is that older adults not only pursued the text messaging intervention through online platforms, but they rated by the end of a 13-week period of different kinds of text messages, they rated them as the highest contributor for change. 75% wanted to keep getting those text messages that helped support their change process in reducing their drinking. 66% thought the content of the message was more important than timing, and they wanted more messages and more interactive messages. This is really important. Older adults may not engage with smartphones or, things that require a lot of touch screen, and need a lot of contrast, but text messaging is almost universal at this point. And a lot of older adults text message if they don't do some other sort of interaction with technology. So I will just leave you with this. This is just descriptive. It's the percent of improvement on alcohol use and with different ways of measuring it. And what we see is that the older adults really like this tailored approach, something that says their name, something that takes into account their particular issues. When we look at the people under 50, they like some tailored messages, but they also like to hear about the consequences that they're trying to avoid. That's that loss frame scenario. And then finally, we also looked at other health indicators, and we see that game frame messages, what are the pros of changing your drinking, really helped with reducing alcohol problems, craving, and depression. Whereas for the under 50 crowd, we have, tailored messages seem to be doing okay, but it's really the loss frame messages again for the alcohol problems. And with that, speedy presentation, I will hand it over.
Dr. Kerbers, thanks so much. Dr. Roy, Mrs. Francis.
Yeah, thank you. Let me go ahead and share my screen here. Hopefully you all can see that. So thank you so much for having us. So my name is Pyle Roy.
My name is Sharia Francis.
And we are from the UPMC Addiction Medicine Consult Service, and we're based out of UPMC Presbyterian. Thank you to Dr. Morano for a great introduction. I think a lot of the points that you highlighted, we're going to see in our patient case. And thank you to Dr. Kerbis for your land acknowledgement. And we were just talking about how we would not have guessed that older adults would be really accepting of texting. So I think that's something I'll take away from this. Yeah, so today we are going to talk about serving older adults with substance use disorders and really try to take it to the bedside because that's what Sharia and I do. So our objectives for today, we will review challenges associated with medically managing an older adult with substance use disorders. And I should clarify that, we work on a medical surgical unit as opposed to like a level 4 addiction treatment unit, which I think is a little bit different and, just has its own unique challenges in managing these patients. And our second objective for today is to provide insight into social work interventions that can improve the care of the older adult with substance use disorder. So I'll present our case. This is Mr. WB. He's a 65-year-old gentleman, and he's got a pretty extensive past medical history that you can see here. So he had a pituitary microadenoma, he's got COPD from smoking, high blood pressure, anxiety, hepatitis C, severe opioid, alcohol, and tobacco use disorders. He also has chronic pain, being treated with Suboxone for that, plus his opioid use disorder. Multiple concussions, he's had a lot of falls and subsequent post-concussive syndrome, and he also has atrial fibrillation. Past surgical history, so he had that adenoma resected. He's had multiple orthopedic procedures on his arm, his elbow, his knee. And then family history, he's got extensive history of MI, so that's myocardial infarction or a heart attack, multiple cancers in his family, and his brother has a history of cirrhosis secondary to alcohol use disorder. In terms of his social history, this sort of is an amalgamation of multiple histories that have been found in the chart based on the H&Ps that he's given. So I think this is a combination of what he's told people and the history that folks have gotten from him. So sometimes can be a little bit inconsistent, but this is what we found. So tobacco history, smokes anywhere from 3 to 4 cigarettes per day to 1 pack per day. Last heroin and injection drug use, that was pretty consistent around 2013. He lives alone, he's on disability, but he used to work maintenance and other sort of odd jobs. He does have a daughter and 6 grandchildren. In terms of his alcohol use, this is really the sticking point. I'm not sure how much he was drinking. There's definitely a lot of different reports. So, anywhere from 2 to 3 rum or bourbon and cokes per day. Sometimes he would say anywhere from a third to a fifth of vodka daily, a third to half of a fifth of vodka daily, or a 6-pack of beer daily, sometimes in combination. What we do know is this looks like pretty unhealthy alcohol use. And this is his admission timeline, and I went from 2019 to 2021. So he had a kind of a 2-year period where he was admitted pretty frequently. And you can see there's some themes in his admissions and some themes that Dr. Morano brought up. So he's had a lot of complications essentially related to his alcohol use, although it's not necessarily apparent that it's from alcohol, right? So he comes in with shortness of breath pretty frequently, and then has atrial fibrillation. So atrial fibrillation is a heart, is a rhythm problem or an electrical problem with your heart, and that can be related to alcohol use. He's also had multiple ground level falls with fractures. So obviously, a lot of heavy drinking, having falls, having fractures. LEE here, that's lower extremity edema, meaning he has a lot of volume overload. He's very fluid heavy. This is often related to having heart failure. That's what HFpEF is, and cirrhosis. So just having a lot of fluid on board. FTT here, failure to thrive. So he's had a lot of admissions for that. So just not really being able to take care of himself at home. And then here you can see, he's had all these admissions between 2019 and 2020. And finally, at the end of 2020, he was agreeable to going to a SNF. So, it took a long time for him to sort of be agreeable to get more help when he leaves the hospital. Again, some more admissions for lower extremity edema. So this admission here, palpitations, a type 2 NSTEMI means like a sort of a mild heart attack. And then, here he's just kind of getting admitted for a lot of similar things. So dysarthria, meaning he's not speaking properly, worried about a stroke. Turns out to be that he just doesn't have enough fluid in him. He's not drinking enough, not taking care of himself. And I put a note here, this is the first time that Addiction Medicine Consult Service saw him. This is in March 2020. And I actually was the person who saw him. And you can imagine March 2020, a lot was going on, and it was pretty hard to do evaluations for folks. We were doing some of his medical visits by phone. And so we did offer him medication. I know Dr. Kurbis sort of touched on naltrexone, so camprosate is another option, which we offered him. And we offered him a lot of follow-up, although, follow-up appointments, things like that. But it was really hard for the patient to be adherent to the medication and to the follow-up. So I'll just highlight some of the challenges to his care. So one issue was that he was often altered on admission. This was because either he had altered mental status from alcohol withdrawal or altered mental status from the medications we gave him to treat his alcohol withdrawal, so like benzos and barbiturates. So these are some quotes from our social workers. So although patient was more alert and oriented today and able to have a conversation, patient would not be an appropriate referral for residential drug and alcohol treatment. At presentation, patient's rather groggy with some slurred speech, but able to hold a conversation. So, the issue, right, is you need the patient to be able to be engageable in order to actually do an appropriate level of care assessment and get that consent to be able to send referrals. He would also minimize his use. So this was partially evidenced by the fact that, he would give kind of these different histories and we weren't really sure how much he was drinking. But I think a big issue was that almost in every admission, he would say that he really wasn't drinking that much until only a few months ago, even though, as we saw, these admissions spanned a couple of years. And, we know that history isn't necessarily accurate. So he would say things like, he never used to drink, but only started a few months ago because of the stress of his housing situation, or prior to 6 months ago, drinking wasn't a problem for him. And this was kind of something that we saw throughout his admissions. Another issue is failure to thrive. So this is not uncommon in the older adult population. So, just as you get older, it can be more difficult to take care of yourself at home. And obviously the alcohol use doesn't help this. So he had minimal supports at home. He was falling frequently. He couldn't follow up with outpatient providers due to just weakness, falls, transportation issues. He would inconsistently accept SNF referral. This is an example of one reason that he had declined SNF. So this is a note from a case manager. So recommend less than 3 hours at this time. So it's PTs recommending less than 3 hours PT at this time due to no assistance at home and multiple stairs to enter. I think he had something like 15 stairs to get into his home. So discussion with patient concerning SNF choices. Patient does not desire SNF placement at this time due to the concern over COVID-19 at SNFs. And that was a really big problem on the inpatient side. Another issue is he had high physical rehab needs. So, one of the social worker notes did mention wanting to refer him to drug and alcohol treatment, but it was really tough because, as you saw, he has a pretty high burden of medical disease, and that can make it really hard to refer people to sort of a lower level of care of drug and alcohol programs, right? So a level 3 or even a level 2, it's just hard for him to be able to go a level 3 program. It'd be hard for them to offer him the medical needs that he has. And then a higher level of care. So for instance, like a level 4, it can only accept people for a short amount of time. It's really about, stabilization and then, sending people down to a lower level of care. And that's pretty tough for him. He also was, he had housing instability. So he felt like it was unsafe to be at home, but he couldn't go anywhere else. And I think associated with housing instability is this difficulty with medication adherence. So he just, he's on the right medications when he leaves the hospital, but he just can't take his meds when he goes home. He says his triggers are his stressors at home, worried about getting evicted, but potentially not safe to be at home. He had a Section 8 appointment, but then developed atrial fibrillation and wasn't able to go. So this is pretty common too, right? People, they get kind of plugged into the system, but they're just not able to kind of manage because they develop these medical issues. And so now we'll go into our second objective. So provide insight into social work interventions that can improve the care of the older adult with substance use disorder.
Thank you very much. So some of these things I'm just going to gloss over. They were mentioned in the prior presentations, but Really looking at, because again, we operate in the hospital, it's very short engagement. Sometimes it can be 10, 15 minutes, sometimes a little longer. But how do we engage patients who are in the hospital who are older adults? So a lot of these things are just core social work concepts. So a gentle, respectful manner with individuals reduces stigma. Approaching the assessment through this holistic process of what is the need, what is the person coming in with the problem, what are some issues at home, like was mentioned with Mr. WB. So we're not, like it was mentioned, we're not looking to diagnose someone with a substance use disorder. We're really trying to do this holistic assessment that takes into consideration the person's whole needs. So showing a supportive, non-confrontational approach versus this assertive style. So we're not going in trying to, tell people what to do, give them orders, but hey, how can I help you? I noticed you came in with AFib. I'm sure that's tough. It's tough being in the hospital. Want to do an assessment with you. Is that okay? Asking permission to talk about substance use, that's found to be very, very helpful in terms of inviting the person into the conversation versus forcing an assessment on them. So communicating genuine interest in the person's overall health. So, and also other social circumstances. With this particular gentleman, there was very tense relationship with his brother. At one point, he was living independently, and then he actually had subsequently moved in with his brother. The previous slides indicated that his brother was also a substance user, so they would have this arguments because of alcohol, but also enable one another in terms of their substance use as well. So again, communicating interest in terms of the individual's overall health and well-being. So again, discussing the substance use in this overall context. So looking at, again, some continued aspects in terms of how do we assess this population. Early adulthood shows the greatest amount of substance is alcohol that was mentioned in prior presentations. So, alcohol is a problem with this population. And because of guilt, shame, remorse coming into the hospital because of, let's say, ground level fall, there's, with this population, less likely to report alcohol use. And that's why we try to normalize it, include it in our overall assessment. So older adults are less likely to communicate alcohol use than their younger counterparts. Also, this diagnosis of a substance use disorder is much more difficult because it hides in these complex medical conditions. So the previous slide indicated that he had come in for a lot of varying medical diagnoses. However, there were some things that were similar. However, alcohol use is sneaky. It can hide in with these other health conditions that obviously in terms of medical urgency are much more likely to be looked at. So sometimes the substance use can be overlooked. So barriers to treatment. What gets in the way of older adults entering into treatment? We talked about shame. We talked about stigma. In terms of substance use, I've encountered that a lot in the hospital. Oh my goodness, I fell again. I was trying to do better. This is my second time in the hospital. So we hear these things going on. Isolation, we have a lot of people in terms of our surrounding states who don't have close family. Even in this area, some individuals don't have family members out of state. So inability to pay, insurance barriers. People are most likely retired, not working, Medicare A and B, can have limits in terms of medication, co-pays, et cetera, and being able to afford their medications. So difficulties with transportation, so accessing the treatment that we're trying to encourage individuals to tap into. So definitely understanding resources within our areas. Sometimes people get lost to follow up, like this individual, Mr. WB. He eventually went to a skilled nursing facility, So that precluded him from inpatient drug and alcohol treatment that he was eventually willing to go to. So he just wasn't strong enough, needed to get some more support, but then it's left up to other individuals to follow through with that. And sometimes, again, in the severity of his medical condition, the need for substance use treatment is lost. So some lack of support. He had one daughter, grandchildren. Now this was both a motivator, and also he only had that one daughter. He had some siblings. So there was at the same time a lack of support, but also that was a strength of his as well. So understanding the particulars of support, seeing it as strengths as well. So again, substance use can be shameful. Understanding how we can intervene in creative ways, emergency rooms, primary care settings, using the different interventions that was mentioned already, medication that was mentioned as well. Also connecting to case management, support groups if they're interested. So this individual actually had two case managers, one from the UPMC health plan and the other from the community. So tapping into what providers that individual might already be tapped into, and also assessing from a holistic standpoint what interventions that person might benefit from, and having that conversation early and often. So from this social work process of engagement, assessment, and intervention, assessing from a holistic standpoint, getting to know that person, building rapport quickly, using screening tools are important, knowing the treatment that's around with that individual, understanding support groups that might be in the community. There's a lot of grief and loss that I've come in contact with. So understanding the supports in the community, medical wraparound, medication adherence, also involving family early and often. Again, those are the strengths with individuals. Oftentimes the motivating factor for people to enter treatment and continue. He was very, very motivated for his to be there for his grandchildren. We had many conversations about that. And then my other social work colleague as well had conversations about how he can improve his health so that he can be there and have those relationships. So that was definitely meaningful for him. Also considering other maybe less known interventions. There's community treatment teams, IDDT, other maybe wraparound from a primary care perspective that can be involved, seeing if there's social work and the primary care system that can reteach in terms of medication adherence. So again, we have to be creative in terms of our interventions with individuals and making that intervention very specific to the person. So when we talk about interdisciplinary teams, that is so key. Of course, here we work with interdisciplinary teams comprising of physician, nurse, social worker, peer, and then from an external perspective, home health, SNF liaisons, and us working together and communicating. So that core coordination is a hallmark of patient-centered care, shown to improve healthcare outcomes, patient satisfaction, that person getting to know the individual that's coming to the bedside, introducing our names. Hey, I'm here for this particular purpose. I'm here to help you with this. Can we talk about these different things? So increases the likelihood for positive alliances. Maybe there's a follow-up phone call that can happen. Maybe there's coordination with a person's primary care physician. And so, hey, I'm not only engaging this person at bedside, but I'm also completing a warm handoff that says, I'm making sure that not only you have this care in the hospital, but also we're making sure that you have the follow-up as well. Continual assessment and reassessment. Again, there was confusion when we started to engage with him. He became more alert as his withdrawal and other health conditions started to stabilize, having more in-depth conversations about his plan, what his motivation was, and also what his goals were, what his priorities were, what he wanted to see in terms of his discharge plan. So again, this coordination across healthcare systems, individualized plans of care, understanding who is leading this person's care in terms of our setting, the primary team providing recommendations to the team for consideration, and then continuing to share data, to share information, communication, in order to inform the patient, to inform the person who is also the support. And again, in this case, that was his daughter. So Dr. Roy is going to talk about some successes in terms of his care.
Yeah.
Just
So
2-minute warning, okay?
yeah, great. So a few successes. He was able to receive physical rehabilitation at a SNF. He did get started on medications for alcohol use disorders, on Camprosate, and was able to kind of demonstrate some adherence with that, in addition to his Suboxone for his opioid use disorder. He followed up with outpatient providers, so he did have a few outpatient appointments and endorsed alcohol abstinence at least one of them, at least for a short period of time. So, we take these little baby steps, to kind of like advance what we're hoping for this patient. So it might not be everything that we're hoping for, but, a little bit at a time will make an improvement. So some key takeaways. So acute and chronic medical conditions can often take priority over substance use, especially in the older adults. So make sure to get a good, thorough substance use history using a non-confrontational approach. Offer older adults treatment. They are more accepting than other age groups, and make sure to kind of know your resources in your area and link patients to wraparound services, both wraparound services at home and in the community, and then within the medical treatment community as well. So these are our objectives, and I will take questions. Thank you.
Thanks so much. I want to thank all of our panelists. It was really, first of all, I know it was challenging to stay on time, so I appreciate everyone staying focused with the time and being able to leave a little bit of ability for questions and discussion, and really the breadth and depth that the four of you were able to provide. Also highlighting what was so powerful for me, the unique role of social work, but also the importance of social work within this a larger system and interprofessional care. So if people can use the raise hand function for questions or put questions in the chat, we'll be there, you'll call on people or read their questions. But I thought I'd start off, Dr. Kurbis, with a question for you. When we talk about age-appropriate interventions, we know that age intersects with many other aspects of our clients' identities. And I'm wondering if you could give an example from some of your work. I know you've done some work with older sexual minority men or individuals with HIV or international older adults. What are the things that we should pay attention to when we think about how age intersects with these other types of identities?
That's a great question and could be a whole nother webinar.
Couple of examples.
But, one thing that occurs to me is that in a group, we did a study with men who have sex with men, and the older men there, they didn't have just one layer of stigma, right? There was the stigma of being in the queer community. There was a stigma related to, but within that community related to age. And, for those of you who are maybe not aware, but particularly among men, the obsession with youth and looks is so powerful. And so as the men aged, I had a client who had been somebody who went to clubs and wore leathers and really had this wonderfully sexually free life. And then he started to get rejected because he was too old. The people at the bars where he used to hang out were saying like, Grandpa, you're too old for this. And so his drinking actually increased because he started to be socially isolated from the community that he felt a part of. Similarly, a lesbian who was 65, she was my heaviest drinker ever, 100 standard drinks per week. And you'd never know. I mean, her tolerance was just amazing. She was also rejected from her community through sports. So she had been a softball player and she had aged out of the softball, even though like she was more spry than I was. She was far more in shape than I was at the time. She could play softball, but they didn't want to take the risk of her playing. And so she lost that community. So I think it's like the intersections of stigma with HIV stigma also plays a huge role in the continued use of substances to cope with the stress or pain.
Terrific, thank you. Dr. Roy, Mrs. Francis, I'm wondering if you could talk a little bit about how you engage patients when they say they aren't really interested in treatment, and maybe a little bit how you leverage some of the interprofessional nature of your work.
Sure, thank you. So, we have to build rapport pretty quickly, in the hospital. So therefore an assessment or what have you, or to look at placement, et cetera. So I kind of start wherever the patient is. What do they want from their admission? What is quote unquote success? So, or what is, their idea of a plan that oftentimes does not fit what we might have envisioned. Again, we have to prioritize safety for that individual, but we can bend some places, we can, collaborate with that. Again, we're not trying to necessarily, especially with my role, diagnose the substance use disorder. We're trying to build relationships so that the plan and maximizing safety can be a collaborative effort versus a dictatorship, if you will. I bank a lot on my relationships with people. So that's the leverage that I use, communicating interest in who they are as a person, and who they envision themselves as this person who is aging, and what that picture may be, what it looks like, how it can be different, but still fulfilling to that individual. So there's a lot of components that go into that, but that's a start for me.
Yeah, I bank a lot on Sharia's relationship with the patients. So I think it's really helpful to have like multiple people on a care team go and talk to the patients. So we have the provider, we have a social worker, and we have a peer usually see every patient. And I think it's really helpful because everybody has a slightly different role, but we all have the same goal, right? Which is to get the patient where they need to be or where they want to be. So sometimes, the patient might not appreciate a medical role or a medical approach. Sometimes they do. And then that's helpful to have a social worker talk to the patient, and then they appreciate these other resources they have, and then maybe they want to talk to me again because, oh yeah, now like medication is clicking a little bit more for them. So definitely interdisciplinary really helps.
Terrific, thanks. Dr. Morano, I have a question for you. If you could maybe speak to the students we have on the call. Many of them are about to graduate next month with their MSW, and I'm wondering what advice you would have for them if they're interested in working with substance abuse in older adults.
Well, thank you for the question. Just like you, Danny, to try to get two for the price of one here with these questions. But they're all very relevant. I think, and it goes back to both the combination of what we've been hearing. When I do teach students that Social Work 101 is not necessarily starting where the client is, but knowing where you come from. So I think in particular, because to start where the client is, you have to be comfortable and solid within the foundation of what you're bringing to your work. And it's our life experiences that we bring forward. So particularly working with older adults and looking at younger practitioners, what do we know about the aging population and what biases have we formed that might influence the work we do is critical. I also think that recognizing the importance of having a solid theoretical foundation in the work you're going to do. I think that it's easy to defer to being an eclectic practitioner, and that sounds, I think, glamorous, but in fact, I think before you can get to become eclectic in your work, you need to have a solid foundation from some orientation, and then build upon that. I think the third thing is through your studies as a student, I hope you took good notes in your policy classes, because everything we're talking about is driving the practice we do, whether it's the implementation of specific types of interventions, to how they're going to be evaluated, to how they're going to be funded. And to steal a line from a movie, just follow the money, and you'll see where the support is going. So be aware of that. I think intersectionality we've heard about in terms of recognizing that our clients are faced with a myriad of oppressive factors that have systemically not only altered, or I should say, distorted our approach to practice based on a white, Eurocentric population that fails to have the cultural humility to recognize that even the best of our services are like shooting arrows into the sky, where we hope, we find the right target, but I think we're missing a large part of the populations that could benefit. And then lastly, the intersectionality of, as I framed it, within those social determinants of health, and recognizing that. When I started with what goes around comes around, there is that reality that what we're facing now with the older adult population is no different than what the education system faced when the cohort was going through the education system, through employment and housing. And now, the bulge of this large number of individuals needs to have a response that's equal in measure to the demand that's being put on the systems. And I think if history tells us anything, we're just beginning to see the precipice. That cohort is just in our 70s to 80s, early 80s at the latest. We haven't even seen what happens when we get that cohort moves into the late 70s, 80s, and 90s, and how the insidious impact of substance abuse disorders, regardless of substance, it is going to drive demand for a wide array of services in the long term, both community sector as well as the residential sectors. Was that an answer?
That was an answer. No, thank you very much. I want to ask our other panelists to maybe pick up on Dr. Morano's point, either Dr. Kurbitz or our UPMC colleagues, about the systemic issues and barriers that are there for older adults attempting to enter into the system, and where you see opportunities for those of us who are social workers to really advocate across systems to increase access to care.
So I'm sure my colleagues have more to say on this, so I'll be very brief. But in my experience, substance use treatment programs tend to have an age limit of 65. And if anybody has serious medical issues, most intensive outpatient programs and outpatient facilities will not accept them as a patient because they don't want to take on the responsibility. So I think one area of advocacy could be educating that, actually we have health problems and complications across the lifespan. It's not just unique to older adults. And then I think that also there was a question in the chat about whether or not it's difficult to get someone who's on medication for AUD or OUD into a skilled nursing facility. And in my experience, it is because they don't have the staff or the medical providers that are licensed in things like for Suboxone or for buprenorphine. And so it ends up, or methadone. I mean, it just gets really super complicated, and a lot of facilities, in my experience, haven't wanted to deal with that.
Thank you. Dr. Roy or Ms. Francis?
So, yes, there are several barriers actually. So from an outpatient perspective, I know I've come into barriers specifically with from an insurance perspective. So a lot of outpatient providers, let's say we're referring someone, that person's agreeable, et cetera. And a lot of providers do not accept Medicare, different formulations of Medicare as well. And then some other providers who do accept might have a cap in terms of numbers that they're willing to accept. So there's either one or the other or both in terms of referring someone who might be an older adult. Also, from an inpatient perspective, a specific provider may or may not have specific age appropriate interventions or sections for older adults specifically. So that could be and has been a barrier in my experience. I've heard things like, I don't want to go to rehab with a bunch of young people. I want people who I can relate with. So that's been a barrier as well. In terms of the highest level, so level 4, inpatient drug and alcohol. So someone who, let's say, has pervasive mental health, you can actually be too sick for level 4. So some individuals with multiple severe chronic health conditions would not be appropriate for level 4 because there's not the stamina, endurance, attention for treatment. The medical condition now has become primary. So that kind of eliminates that option. Or this person has a severe alcohol use or other substance use disorder. And level 4s usually are shorter. So you're 7 to 14 day, depending on if they're, detox, rehab, et cetera. So it's not long enough. And then you go down to the original problem that I mentioned for stepping down. Those individuals don't want to, they want to go home, might have a pet at home, might not want to go again because of, they don't want to go to rehabs with individuals who are younger than them, et cetera. So there is definitely several barriers that come up when we're trying to offer treatment and place them appropriately according to the severity of their disease.
Yeah, I just want to echo the being too sick for a level 4, which seems kind of outrageous. Because a lot of patients are, they're not sick enough to necessarily stay in the hospital anymore. They can go home, but they really do have a severe substance use disorder. They need treatment, but just medically they're too sick. This happens in our older patients. And so now what do you do? Because they really need treatment for their substance use, their alcohol use, and they're not getting any targeted treatment. And I did just also want to echo, it can be really challenging to send folks not on medications for alcohol use disorder, so naltrexone, camprosate, disulfiram. SNFs will take patients on those medications, but when it comes to buprenorphine and methadone, which are treatments for opioid use disorder, the SNFs often say they don't have the capacity to take care of these patients. I think there's a lack of will, actually. There's actually been lawsuits in Massachusetts over this, that it's a violation of the ADA. So I think we need to report this a lot more. Actually, I've been meaning to talk to you about this. So yeah, I mean, it is definitely a huge problem, but also potentially a violation of the ADA.
Mm-hmm. I think too, in terms of stigma and bias, that is not related to age. So stigma in terms of handling patients who have both, again, severe, they're comorbid, so mental health, substance use. In terms of our current state with healthcare, the limited staff available with specified training to effectively work with individuals coming with these very, very complex problems. So oftentimes they are denied because of that. Do not have the capacity to attend to the needs of the patient, quote unquote. So oftentimes we come into this dual problem with the person has a lot of need, they're on medication, and there are not physicians available with the X waiver, or there's not an associated methadone clinic with that particular skilled nursing facility. So you have multiple barriers with an individual patient.
Yeah, thank you, Sharon, for your comment in the chat. I don't know where these patients go. It's a huge problem.
Yeah, so to that point, sometimes we incorporating family members who, we might have to search for individuals, friends who might be as family. So again, these creative plans that involve, multidisciplinary teams. So do they have a friend? Do they have a family member? Can we maximize home health care and understanding that, hey, this is not the optimal plan, but because of barriers with skilled nursing facility placement, this is a plan that will work with the highest level of, let's say, home health care. There's also medical wraparound agencies that specifically provides services for individuals in their home who struggle with, medication compliance, isolation, these things. So knowing resources, being able to assess appropriately, submit the application early so that we can complete warm handoffs and they can put a face to a name with these different agencies that we might be referring, because that can be anxiety provoking as well.
Great. And Sheree, I really appreciate your comments, and afterwards we will send out contact info if people want to be able to follow up with any of our speakers. But I appreciate you dealing with the depth and complexity of the medical comorbidity issues, and also acknowledging that sometimes a barrier might be that someone lives alone with a pet and they don't know what they're going to do with that pet, and that in Allegheny County, we actually have a foster pet program for when an individual either going to treatment or going to be hospitalized. So this is things that social workers worry about that are really, really important, because if there's not someone to care for the cat, the person's not going to go into treatment. Alicia Page, I know you had your hand up earlier. I wanted to give you an opportunity if you had a question.
No, I'm good. Thank you.
Okay. If anyone else has questions, please use the raise hand function. We have some questions in the chat. I just wanted to make sure we got to them. I'm wondering if either Carmen or Alexis, you know of any examples of substance use treatment coordination options that have been tailored for older adults that are living in senior apartment settings, or pre-SNF, or is this really kind of the work we're doing right now, really preparing social workers who are going to be in these settings to be more aware and cognizant of substance use issues?
So I know of some things that are happening, but it's not official to substance use among older adults. It's that I've been going in and doing in-services and helping bolster existing care coordination programs for housing. So SROs and a lot of NORCs as well. So to get those care managers up to date and kind of understanding what to look for. I will say that one resource, as my colleagues were talking, is I would contact Hazelden, actually, because if you're looking for resources in Pennsylvania, they have a whole program designed for older adults with medically complicated issues. They have like a inpatient unit and then a step down care, and it's pretty incredible, actually. So, that might be a resource for people to reach out to them to see if there's something more local or what have you. And then, I think that the system is lacking, period. I mean, I think that's like a major key point and takeaway, is that nobody's everybody's trying to catch up, right? Like the train has left the station and we're all running to try and catch the train. It's just, and, I think that Ms. Francis really did a great job, as well as Dr. Roy, in illustrating the complexity, right, that you have in inpatient. And I don't think that outpatient is that much less complex, right? Like, I think we're dealing with complexity in all sorts of settings. Our systems are not made for complex. We have a siloed healthcare system that likes to treat, a cardiology problem, and or a mental health problem. And so it really is just so challenging.
Yeah, I would add, especially if we look at the demographics of this aging population, there's a significant percentage of older veterans. And thinking about the VA system, I know I'm biased. I am on one of their advisory panels, but they are leading the charges both in the area of medication deprescribing, so looking at the intersection of multiple medication and how challenging that is, and the over medication and how we can do a better job, do more with less. So I would certainly suggest the VA system, both in terms of their work at that end, as well as within their community living centers, where they really have been focusing on, I think, a more holistic approach to providing wraparound services for the aging veteran. The problem, I think, with everything here that we're talking about, though, is, again, I'm sorry to repeat the follow the money, you know, the treatment. And again, I think we are limiting our discussions into tertiary care, which I think, you know, does a disservice to the preventive side of this equation, to try to get ahead of it. But I do think we need to look more upstream a little bit to see what we can do. But when we look at the tertiary care models and how they're driven by ICD-10 codes and diagnostic criteria, will sound completely politically incorrect or inappropriate, I should say. The highest reimbursed charge is the treatment that's going to get the priority for the patient. So when we look at reimbursement for service delivery, what the provider gets to spend the time to do the work that my other colleagues spoke about, to do an adequate assessment, is not where, you know, the providers can spend their time. It goes to this tertiary model of service delivery, acute care and acute responses. So again, I think policy drives practice. Until we shift our priorities, I think we're always going to be rolling that boulder up the hill. So that's some of my thoughts.
Terrific, thank you. And maybe in that spirit, and talking about policy, in the chat, we have a comment from a representative from the Pennsylvania Association of Area Agencies on Aging. Do you want to unmute and tell us about the initiative statewide that you're putting forward?
Oh my goodness, I would love to. It's nice to meet you all, and what an incredible presentation. It was excellent. I was hired, I've worked, basically, my name is Lynn Cooper. I've worked in the mental health and substance use disorder field. I was actually a lobbyist for 27 years in that field, and spent a lot of time working on regulatory issues and funding issues and assisting our members with things like licensing and staffing issues. Anyway, had a wonderful time for 27 years and decided to do something different, and started working for the Pennsylvania Association of Area Agencies on Aging. And they hired me specifically to help address the incredible lack of services available for older adults in the state of Pennsylvania. And I'd like to tell you we're an outlier, but we're not, of course, and all of you know that, the entire country. And given the numbers, we're screaming from the rooftops that we're talking about huge increases in the next 7 years and 6 months. I mean, they're the numbers that we're looking at, you know, as much as 30+% increases. And our systems are not ready. We have problems in our protective services programs. One of the major things that we do is we investigate you know, any kind of abuse or concern for protective services. And we have had so much trouble when we identify a person that has a substance use disorder, trying to connect them with any kind of help. And then, of course, what happens if they don't get it, we're back again in a month from now with another. And you all have shared incredible examples of that. But what we're doing, we're working with an organization called E4 Center of Excellence. And they received a $3.5 million grant to by SAMHSA, Substance Abuse Mental Health Services Administration, to simply address the disparities that exist in behavioral health. And we've partnered with them. We have an academy starting at the end of April. We have the Department of Human Services, Office of Mental Health and Substance Abuse, Department of Drug and Alcohol. I could go on and on. Lots of statewide leaders that are going to be sitting down and trying to strategize on what we can do. I'll be quiet now. Thank you for the opportunity. It's very exciting.
Thank you. So nice to meet you, and I appreciate that. I want to thank our panelists. I really, again, this was just terribly exciting to be able to have this discussion, to have the turnout and the interest, I think maybe the tide is changing in that we can really start paying more attention and better serving older adults who are facing these challenges. So I want to remind everyone for your CEUs that you'll need to complete the post survey that Elizabeth will be sending out. And I also want to give a special thanks to Elizabeth for coordinating and supporting our efforts in doing this. It was really terrific. So again, Alexis, Sharia, Pyle, Carmen, thank you. It was, we all have things that we hate about Zoom, but the opportunity to bring everyone together to have this discussion, I think is really one of the really special things. So I hope everyone has a great rest of the day. Thank you very much. And you'll be getting some follow-up emails from us.
Thanks so much.
Yeah.
Thank you.
Thank you.